So let's first invite up Dr. LaGanke, came down from Cullman, and he'll be speaking also at our August 20th program. So I hope to see you all there as well, and remember to tell all your friends.
Thank you, Stu. Thanks for supporting the program, coming out into the country to support these programs so that we can learn more about MS. And what, yes, I got you. So, if you can't hear me, go. And so I really appreciate this venue because most of the talks we give are pharmaceutical sponsored talks, and they're regulated. You can only say certain things. You're bound not to say information that's out there. You cannot speak to some of those issues that are parts of studies and actual results. We can't speak to them if they're not in the medication label, for example. So this sort of opportunity is a neurologist's dream, to come and be able to philosophize and say whatever I want to say, and you're going to get a dose of that and you take it with a grain of salt. I think the main message is you have to be your own best advocate, and you do that through knowledge. So the more you know about how the process works, about various things, the more informed you are, the better I think you can take care of yourself. So, and I think you're limited in having access to things because of the nature of the regulated world that we live in. So this hopefully will be an opportunity for you to learn some things and that's the goal always of talks, is to leave this room with more knowledge than you came. So that's my charge tonight, and we're going to get started. So self-reliance. Trust your instincts, form your own opinions, make good choices. So you get bad information sometimes, and sometimes you're in a setting with a professional and you get you're told some things and you just don't think that's quite right. And you are entitled to make your own opinion, and you can make your own choice. And you can say, no, I don't agree with that, or this is what I believe. You're certainly entitled in our encounters to have your own opinion. And hopefully you have more knowledge to speak to that opinion. That's what we're going to try to arm you with tonight. So yes, knowledge is power. Perspectives are very different. And so I come to the visit, let's say, with you with knowledge about trial results, information that you don't have access to online, and side effects that really do occur, as opposed to that list of things that isn't really the list of all the side effects. And I bring that knowledge and just how patients have performed in certain ways, and certain characteristics of patients that might make them more likely to improve on this treatment as opposed to that treatment. And you bring your life history and what you're comfortable with and what you see your goals are. And the goal is to try to marry those two and have a good outcome. Because we're really teammates. It's not I tell you to do this and you do it. It's we want the same thing. We want you to function as best as you possibly can on this planet neurologically. That's our goal. That's our shared goal. And regulators don't necessarily share that goal. They have a different agenda. They have to balance the books, or they have to speak to their board or the stockholders or something else. So their agenda's a little bit different. They come with a little bit different perspective sometimes. And so we need to ally and try to do what we can to have the best result. So this is basically my observations and experiences on certain issues. That's what I'm going to talk about this evening. So we hear a lot about evidence-based medicine, and it's kind of like separation of church and state. Where that started out was to give people individual freedoms for their own religion, to be able to express their own views and not have someone in government tell them how they need to practice religion. And then it gets turned around where you can't say anything religious, or you're not going to get funded and you don't have a voice whatsoever. I mean, that's how it's been turned around. Well, evidence-based medicine was created, the concept was created in Canada for us to look at, use the best evidence we have in the various clinical trials and experientially, and then use the clinician's vast experience and try to come up with the best product. But now it's, where's the data to prove that that is so? And if you don't have it, if there's not that evidence, then forget it. Can't do it. Not going to allow it. So, when we try to get a medication that we know works for a certain symptom, for example, if there's not evidence to prove it in a clinical study, often insurers won't pay for it, even though we have a lot of experience and it's very helpful. And yet we have to use more toxic medication in order to have the same result, which puts you at risk. So, evidence-based medicine, we would love to have proof of everything we do, but that's just not the case. There are so many nuances, and individuals are so different. They have other medical histories that they bring and experiences that you can't possibly conceive of all possibilities when you conduct trials. So we do the best we can with our experience and the experience of the medications in trials and otherwise. So we try to use common sense in coming up with the best solution. And we've gone to school a long time. And to kind of counter evidence-based medicine is a quote that I love, Sir William Osler: "If it weren't for the great variability of individuals, medicine might as well be a science and not an art." And it truly, truly is an art, and people try to make it a science all the time. And there is science to it, but it's really an art of adapting the knowledge we have to the person in front of us and coming up with the right solution. So I'm going to go over a bunch of facts or issues and have some commentaries. So what's the incidence of MS? So in the U.S., 400,000. You'll see it. I gave a talk in Huntsville last night. That was on the slide. Gave a talk last week in Nashville and Columbia and Murfreesboro. That was on the slide. It's on every slide. That's from 1990. One person in the United States every hour gets diagnosed with MS. One person does not die every hour from MS in the United States. So the numbers should be different. Hey, but we don't have a census number. That's the number we last have as kind of a census number. So that's what we're stuck with. It's 26 years ago. And world, 2.3 million. Much higher than that. Funding is given based on incidence of conditions. So we're allowing ourselves not to be funded well by continuing to use these statistics. That hurts you. That's not good. So we need to be advocates and say, no, we need to kind of find a way to collect data and have a better census. And at least, even if it's not ideal, we're going to have a much more accurate number, which then helps us to go after funding, which helps you at the end of the day. Okay? Genetics. This is a genetic condition. MS is a genetic condition. There's a Canadian identical twin study from Ebers that shows 330-time increased incidence in female-female identical twins, 45-time increased incidence in male-male identical twins. They didn't necessarily live in the same household, so it wasn't all environmental. So we know there's a gene component. We've identified over 100 genes to this point. There are many more to be found. Vitamin D, Epstein-Barr virus, smoking are environmental factors that play on genes. And there's this whole concept of epigenetics where, let's say the Epstein-Barr virus, it infiltrates our DNA. When we get mono or we have exposure to the Epstein-Barr virus, which 95% of us in this room have evidence of being exposed to Epstein-Barr virus, whether you had clinical mono or not, it inserts in our DNA. And it shuts down certain regions and it opens up certain regions. And we even think that can be passed on to our children. Okay, so it doesn't have to be a change in the DNA. It can be, as far as altering and mutating, it can be an insertion of something and that gets passed on and that changes a lot of things. And vitamin D has many, many, many receptor sites in our DNA. And they turn some genes on and turn some genes off. So there's a lot to it that not only what we get passed on downstream, but what we get exposed to also affects our genes and our maybe our course of MS and what we possibly might be exposed to that's going to worsen our MS. Home run of therapy. So home run of therapy is what I espouse we should strive for at this point in our medications. And I thought about it in about the year 2000. I said, okay, if I had a choice, we had a few medications around to alter the course of the disease. And I said, if I could have the best outcome I possibly could at this point with what we have available, what would I want out of that treatment? Well, I'd want it to be well tolerated and safe, because if I felt lousy a day or two every week for the rest of my life, that's not really a win. I'd want to have no more relapses. I'd not want to get any worse on my neurological exam, and I want no new MRI lesions. And so I said, well, why can't we strive for that? And that's back in the day when that wasn't the case. We said, well, 33% reduction in attacks, that's pretty good, because it was better than what we had before that, which was nothing. And so we should really look to have that as a goal. And you should have that as a goal. At least you know what you're looking for and why you're taking that shot, that pill, that infusion. This is why I'm doing this, because I want to shut down this disease, and I want to do it in a well-tolerated fashion. And if I'm not achieving that, I need to discuss this with my healthcare provider. Is there something else we can do? Because I had a relapse, or my MRI is getting worse, or neurologically I'm worsening. Can we do something about it? Not just go along. And that's for you to take charge and say, this is not acceptable. Just kind of an extra point, every medicine that we have has hit the home run in one individual or another. So every one of the 12, 13 we have approved is hitting this home run in somebody. So it's not that some of the medicines aren't fully effective. They all have the ability to be fully effective. They're just, some are more likely to do it in certain individuals than others. We need to know when we get diagnosed that we need to exclude other conditions before we're diagnosed. So there are conditions out there that mimic MS to a T. Same attacks, intervals of nothing, MRI lesions the same. So you should have these blood tests and other things done before you're officially diagnosed to make sure that you're not taking a treatment that you don't need and missing out on a treatment that you do need. NMO, neuromyelitis optica. That's a condition that causes large lesions in the spinal cord and an optic neuritis that's quite severe. And in its glory, without any treatment to combat it, it causes blindness and quadriplegia. It's a much more severe condition than what MS tends to be this day and age. And so if one has pretty significant optic neuritis or a large spinal cord lesion, make sure that you've been tested for this. It used to be that you couldn't have any brain lesions with this condition, and now you can. It's allowable in the diagnosis. So if you have really bad optic neuritis, don't respond, or recurrent bad optic neuritis and large spinal cord lesions, this is a condition we need to be aware of because the treatment is drastically different. Now, in the diagnosis, there are some clinicians who are very by the book, okay? And if we stayed by the book, we wouldn't have made any progress in diagnosing earlier. So you can tell what side of the coin I'm on. I'm on, we have different camps, and I'm on the camp of more aggressiveness in diagnosing and treating and trying to keep someone as normal as possible. And I know others in the other camps, they have their reasons why they do that. I'm not trying to say I'm superior or my way is better. I believe my way is better or I wouldn't do it, so I'm going to champion my way, but I'm not saying that others don't have reasons why they do things. But what upsets me sometimes is someone who's diagnosed and they go somewhere else and they say, well, it's not MS. Well, then what is it? Well, I don't know what it is, but it's not MS. Because it doesn't fit that circumscribed table that they're accustomed to make a diagnosis, like spinal fluid, which I'll talk about in a minute. But also brain lesions, and I'll talk about that as well. There are some people who don't follow the rule book and have MS for sure. So spinal fluid, used to tap everybody, used to do a spinal tap on everybody back in the 90s. And then we found that there are quite a number of people who have normal spinal fluid who have MS. It used to be considered 95% of people with MS have abnormal spinal fluid. Now there are studies say 70%, 60 to 70 to 80%, depending on the study, have positive spinal fluid that's supportive of MS. But remember, there's not any one test that says you have MS. So abnormal spinal fluid occurs in lupus, it occurs in other autoimmune conditions, it occurs in Lyme's disease. So having abnormal spinal fluid doesn't say you absolutely have MS. It's supportive when we see inflammation, but the absence of it in no way says you don't have MS. And still today, I have people come in and say, well, I had this issue and that issue years ago, but my spinal fluid was normal, so I was told I don't have MS. I couldn't have MS. And they have accrued a fair amount of damage that didn't have to be over time. So spinal fluid has been removed from our latest international criteria to diagnose MS as being helpful in diagnosing relapsing MS for that reason. But still today, I see it every month. People come in and say, no, I just went and had an evaluation and they did spinal fluid and it's normal, so they said I don't have MS. Because they're in that box of this is how I diagnose MS. Subtypes, I want to comment on subtypes of MS. Relapsing remitting, secondary progressive, primary progressive. There's progressive relapsing, which really is kind of falling out and kind of encompassed more into relapsing remitting as one of the subtypes. You don't go necessarily from one to the other. Now, how secondary progressive MS is defined, you have to start out with relapsing remitting and then you end up in secondary progressive. But people in relapsing remitting don't have to go to secondary progressive. And primary progressive is a separate entity. Our terminology makes sense to us who do it all the time, but I understand confusion in the lay world, and you need to know about it because I have to answer this in clinic several times. I have people who come in, many since the first of the year, said, I'm still waiting to go in remission. And I say, well, what do you mean? They go, well, I'm not normal. I'm not back to my normal state. And that's what they perceive as being in remission. I'm normal. I'm free of, like in cancer, you're in cancer remission, you're free of cancer. So it makes sense to think that way. That's not how we use the term remission in MS. Remission means stable. Doesn't mean normal, it means stable. So if I had an attack and I was paralyzed on the right side and I had some improvement, but I was still weak there, and that went on for months. It was just the same old, that's my new normal, so to speak. I'm in remission. I'm not back to baseline, but I'm in remission. I'm not continually worsening, which is what progressive MS is. And then the other concept of, well, I think I'm now in progressive MS. And I say, well, how do you figure that? And they say, well, 2 years ago, I was walking independently, and now I'm walking with a cane, so I've progressed with my MS. That makes sense, but that's not how we term progressive MS. Progressive MS means the baseline is continually worsening. So people with relapsing remitting disease can have progressive deficits, but it doesn't mean they have progressive MS. So you need to know the terminology so you feel confident and you're getting the right treatment and you're where you think you are. Because secondary progressive often has a negative connotation to it that, oh, I'm in progressive MS now. It must be really bad. And the other thing, I don't like the term secondary progressive nowadays because one, it kind of says that, oh, you're in a progressive phase of MS. It's you know, we're kind of don't have any treatments left to offer, and it's a bad situation. Well, really what it means is that the old lesions have worn out a little bit, and a deficit that you had from ago is worsening. And fortunately, It's not the same as it was when my mom had the disease, and it was like the slinky effect, where the attack this year worsened 8 to 10 years later, and then next year's attack worsened, and it just went like so. Now, what we're seeing when people go on to treatments after they've had the disease for some time or a little time is we see limited secondary progression. So 8, 10, 12 years later, that right leg that's weak is getting weaker. And the leg gets weaker, and it may get to the point where it's not very usable at all. The old lesion is wearing out, and it just doesn't have any conductivity in it anymore, and that leg doesn't work very well. But that's it. It stops there. The arm doesn't go, the other side doesn't go, the vision doesn't go, the cognition doesn't go. You don't go to a wheelchair and then to bed, which is what secondary progressive used to be before we had treatments. So the advent of treatments stop new lesions. If you stop new lesions, those lesions that don't occur can't wear out down the road, and you don't have that extra kind of secondary progression. And we see a lot of people who never get to secondary progressive disease now, who've been out 15, 20 years, because just stopping new things from happening allowed enough reserve where a person didn't go into that secondary progressive phase. So MRI scan, we've come a long, long, long way with MRI scans. Back 5, 10 years ago, we weren't allowed to say that it helps us to use it as a biomarker of disease progression. Now we can use it and say that advancing MRI lesions does predict worse outcomes. So first I want to go over frequency of MRI scanning. How often should you have an MRI scan? It's variable. The general rule would be, especially early in the first several years of disease, if you're stable, you should have one at least yearly. A lot of times the concept now is start a medication, have an MRI scan in about 6 months to serve as a new baseline, because the medication in that first 6 months may not have reached its full effectiveness. And if we wait for a year and we get a scan and we see 2 new lesions, well, did it happen in the first 6 months, the last 6 months, one in the beginning, one in the end? That's really important, because once a medication has reached its full effectiveness, if we see new lesions, that predicts worse outcomes down the road if we keep going on this line. So we want to know, did these new lesions occur when the medication was at its full effectiveness, or was it in that wiggle room time when it was getting in your system, when we'll allow a little bit to happen? So a lot of times you'll see a scan several months after you start a treatment to serve as a new baseline, and from that point forward, any new lesions are not tolerated. Well, what type of scan is it? I had the question last night, is an open MRI scan okay? Well, I understand claustrophobia. It's a very difficult thing to deal with. 45 million Americans have it, so it's not a rare thing. And if you have it, don't feel like you're an alien. It's very, very common. The problem with an open MRI scan, and they're trying to get stronger with the magnet, is that it's just not a strong enough magnet. It's kind of like a low-power microscope and a high-power microscope. You see so much more with a high-power microscope. The stronger the number, the higher the strength. And the unit that's used is called Tesla. So a common open MRI scan is a 0.3 strength Tesla. The standard MRI across America in any town is a closed one is 1.5 Tesla, so 5 times stronger. And most MS specialty places have 3 Tesla, so 10 times as strong as the open MRI scan. So if you're trying to capture some disease progression, a few new spots, you may just totally miss it on the open MRI scan. And you see it so much better. And then it's, how do you slice the images? So there's criteria. You could slice the brain in 6 slices and you're done. You're out of the scan, you haven't been in there very long, and you get these big slices. Well, what's going on in between those slices? So we try to slice it thinner and thinner and thinner so we can capture all the lesions that we possibly can to say this is the baseline, and we're going to make sure that we're not accumulating new lesions. And then what place of the body should you image? So if someone calls and says, well, I have some problems in my hands, I've never had hand numbness before, both hands are tingling, And the clinician orders a brain scan and says, well, good news, you don't have any active lesions, and I don't see any new lesions on your MRI scan. Well, we imaged the wrong place. Bilateral symptom onset is going to be spinal cord, and we need to look at spinal cord. So, there are a lot of clinicians out there who don't do MS 24/7. They take care of a lot of different neurological conditions. They can't necessarily keep up to date with everything and so on. So another reason for you to be your own self-advocate and have knowledge, because they say, okay, well, we set you up for a brain scan. Well, do you think maybe because I have problems on both sides that I haven't had before, maybe there's something in the spine as well? Just asking and see what happens. So it's your body, and you're going to get a treatment or non-treatment, so you might as well step up and try to take ownership of what's being done, right? And that comes through knowledge. In the brain, MS lesions, the classic textbook lesions, are what we call periventricular, right next to the spinal fluid producing spaces or housing spaces in the brain. The corpus callosum, which is the branch of fibers that connect right brain and left brain, so we know what's going on all the time on each side of the brain, because we get input. Input over here is going to this side of my brain, and input over here is going to this side of my brain, and this one needs to know what's going on. So these signals automatically go to the other side and give information to the other side. So that's a classic place for MS. And then what we call juxtacortical, or right near the gray matter, right where the white matter meets the gray matter. Those are classic MS lesions. And then there's that whole big white matter area in between the center and the outside. And that's called the deep subcortical white matter. And that's very, what we call non-specific. You can see that in stroke, you can see that in hardening the arteries, you see that in lots of different conditions. And so some clinicians are boxed in and say, okay, most of the lesions are subcortical. We don't see hardly any around the ventricles or in the gray junction. And so they're not MS lesions because they're not the classic textbook lesions. And so we're not going to, well, I don't know what you have, but it's not MS because they're not the classic lesions. If we autopsied brains, most of the MS lesions are in the deep subcortical structures. And there's a bell-shaped curve, so some people are going to have almost all of them there. And they still have MS, but they're being excluded because they don't fit this box, okay? So I see that a bit. Well, you have non-specific lesions and you're 35 years old. And you had an attack here, an attack there. But it's not MS because you don't have the classic MS lesions around the ventricles or in the juxtacortical white matter. So be aware when someone says, well, your MRI is really not typical of MS. Well, do some people with MS have atypical MRI scans? It's a reasonable question to ask. I get asked a lot, how many lesions do I have? I probably got asked that 3 times today in clinic. And it's hard to say because some lesions over time, they occur right next to each other. And then you get this blob. And is that 10 lesions? Is it 1 lesion? I don't know. So I'm going to give you an inaccurate number to begin with. And then if you had 5 large MS lesions or you had 15 small MS lesions, I personally would opt for 15 lesions over 5 lesions because the large ones are likely to take whole pathways and affect whole function. Whereas if you have a small area, likely you have enough fibers to go around it and maintain your function. So the number can be very misleading. And so what we really look at is what's the volume of the brain involved with MS? Is it a mild amount? Is it a moderate amount? Or is it a severe amount? And that's what we say. We say, and it's kind of crude and it's eyeballish, but we have our own understanding. You have a mild amount, you have a mild to moderate amount of lesion burden. And that's the baseline. After that, every new lesion matters. So then you've had 1 new lesion or 2 new lesions. That's important because that predicts worse outcomes the more lesions that you have on top of your baseline. It's important to kind of understand neuroanatomy. Now, you're not going to be neuroanatomists. But like I said, if you have bilateral limb dysfunction, oh, I started with numbness in my left foot, and I thought I slept on it wrong. And as the day went on, it kind of went up my leg, and then it started in the other foot. That's spinal cord. Outside chance of brainstem, but almost always going to be spinal cord. I have the MS hug. That's spinal cord. Okay. So knowing kind of my right side's affected, we should be looking left side of brain if we think that my right side of the body is affected. I hear a lot, well, any new symptoms since the last time? Yes, I've been having blurry vision. Well, kind of a general rule, if you have bilateral blurry vision, it's very unlikely to be related to MS. It's likely related to something else. Optic neuritis typically affects one eye, and it affects a portion of an eye, one area. This is a blind spot. Now, some people have exceptional cases and really bad optic neuritis, and you may have optic neuritis over time in each eye, and so each eye may be affected. But if you say, just my vision's more blurry, both eyes, very, very unlikely that's going to be MS. And so you don't have to wonder in your head, I have my neurologist appointment in a couple of months and my vision's blurry, I'm going to bring that up because I have MS and we're going to talk about it. As opposed to, well, I know that's not likely going to be MS. I need to schedule an appointment with my eye doctor and I'm going to get that taken care of and move forward ahead of time. Because there are lots of things that affect vision and some you need to address sooner than later. Now, if it's loss of vision in one eye, it's painful to move the eye or a portion of vision, that's optic neuritis, and that you need to let us know. But bilateral blurry vision. So knowledge about these things are really important. Dizziness, very nonspecific. Dizziness occurs in lots of things. And some neurologists say, dizziness isn't an MS symptom. You don't have dizziness or vertigo, it's very rare. But really in talking to people, it's rather common. Now, we may not be able to localize it on a scan, but I don't cast out dizziness as not an MS attack or an MS problem. I will kind of cast out bilateral blurry vision generally with that comment and say, okay, well, you need to go to eye doctor for this. Dizziness, you don't need to go to the ENT necessarily. How did it occur acutely? Ever have it before? Any new medications? Go through those kinds of scenarios to see, is there anything that might have provoked this? Did you have a cold, etc. When old symptoms come back, okay, so the right side of weakness returns, very unlikely that it's a new attack. Very unlikely that there's new damage that's being done. It's what we call a pseudo-relapse, not that you're faking, but that it looks like a relapse, which we think of as new damage, but it's not. It's old symptoms come out when you're stressed. And that can be a bladder infection, recent surgery, you won the lottery, you lost your job, you have a bladder infection, like pneumonia, just they're stressors. You didn't drink, you're dehydrated, you didn't sleep well. That's a stress on the body. You get overheated, which is about to occur more often here in the next couple months. That's a stress on the body, and that can bring out some of your old symptoms. That's not likely new inflammation in the brain, and you don't need steroids for it. Okay? We need to figure out what the stress is and how to combat it. Okay? But a new neurological symptom lasting over 24 hours, we're really concerned that you have MS flared up in some part and it's eating away a portion of your white matter or a portion of your brain or spinal cord, and we want to stop that. We want to address that. When we talk about medical treatments, and there's exercise, diet, physical therapy, occupational therapy, and you heard a good bit about that just a little bit ago. But I'm concentrating on, when we talk about medicine type treatments, there are really three categories: symptom management, relapse management, and disease modification. So the symptoms are, all the things that you have to deal with day in and day out, and that's usually dominates our conversations in clinic these days. Because we generally have pretty good control of the disease as far as new disease lesions most of the time, and it's about how can I improve your quality of life? How can I help that fatigue or that bladder issue, etc. When you go to, like I said, sponsored medical talks, you only hear what's in the label, okay? And that's limiting. That's not the whole story, okay? And when you read the information that's provided about a medication, well, I'm thinking of going on this medication or that medication, and you get that that material, that has to fall within the prescribing information pamphlet. So there's a lot more information out there than what you see. For example, you might go on a medication that says this may cause cancer. Well, I don't really want to go on a medication that can cause cancer if I can help it. But the real story is that medication, when you looked at the trial population over time, the expected number of cancers in the US for age-matched, sex-matched, and race-matched was 146 cancers. That was the expected number. And the occurrence of cancers in the trials was 31. That was an 80% reduction in cancer. Now, I'm not saying that intervention reduced cancer, but it would be nice to have that information rather than I'm reading this may cause cancer, don't want to do it. Well, it may cause cancer because one person in the trial had cancer. So the FDA says if anything occurs during the studies, you have to list it as possibly related. But the rest of the story is it was 80% occurrence less than what you expected. I would want to know that information, but you can't get it in the written material or at talks because it's not in the label. Okay? Placebo and testimonials. The placebo effect is a real effect. People who have diabetes go on a trial, they take a nothing pill, and their sugar is controlled. An MS patient gets in a trial, they go on a placebo, they have no relapses when they're having 5. It definitely changed the course of their MS. That's why we do placebo-controlled studies, or we did them initially, to prove that any kind of benefit that we saw from the intervention was in excess of the placebo effect, which is a real effect, and I'm happy that it is an effect. Thank you. So that comes into play when you read things on the internet. The Dr. Wall's diet, for example. Most of you probably are aware of her, a physician in Iowa who said, I don't want to take any of the medicines, I'm going to go on this diet, and her MS got better. And I don't think she's a charlatan. I don't think she's telling any mistruth. I think she got better. Now, is it due to the diet or is it due to her belief in the diet? We don't know. It's an N of 1. So then to say because it happened to one person, well, now that's the story. That diet does it for MS. That's not necessarily the case. It might be the case, but it's not necessarily the case. And so when you read things on the internet like that, oh, I took the peppermint essential oil and I did fantastic, so MS must respond to the peppermint oil, right? Well, that person, I'm not doubting that they didn't get better and saying that there's putting any mistruth on the internet, but it doesn't prove that that intervention led to the outcome. So I always say a little bit of caution when you read these things and say, okay, that's it, that's the cure in MS. Bee stings, cure of MS. Hyperbaric oxygen, that's the cure at MS. Heard those in the 70s. Again, I'm not saying that people are being untruthful. And I'm glad they got better. I'm glad people improved. If we could tap into the placebo effect and say, okay, this is what you need to do to get the placebo effect and get better without taking anything, I'd gladly close up shop any day of the week. CCSVI, which was the Dr. Zamboni intervention with veins that were blocked and opening those up, and that was going to fix MS. That's kind of fallen to the wayside. It was tested in other institutions and found not to really be as it was successfully touted. That's an example of something that was driven to, this is what we need to do without real good proof of it. So just be careful. Essential oils. I'm glad for symptom management. I wouldn't say that someone feels more calm if they have the chamomile tea or essential oil or this or that. That's great. But I wouldn't go the extra step and say it changes my MS course. It helps with lesion formation. Now, some of them may at the end of the day, but we're not there to give you any kind of proof that it does. And it goes on and on. So just be careful. We're not against natural things working. We'd love for natural things to work, but we also are in a position of responsibility. and science and knowledge. And so if we can't say it, we shouldn't say it doesn't work, it's not good. We should say we don't know. We don't have any good trial information to say that the intervention is better than a placebo. Not that we just discard it as being silly. We don't know. It's just not been tested. So then I'm going to go into symptom management, relapse management, and treatments. So here are some of the symptoms, at least up into weakness. Exercise is not a symptom, but the first 5 are symptoms, and we have lots of things to do for symptoms. But I hear a comment a lot, and I'll ask a question first. How many of you grew up wanting to take medication? I don't see anybody. I hear it in clinic all the time. I don't want to take medication. I didn't grow up. I don't want it. I'd rather not take medication. I don't want you to have to take medication either. But it's responding to the situation. And you don't have to feel guilty about it. You didn't go out and have indiscriminate sex and shoot up drugs and have MS as a result of that. You didn't do anything to go get this condition. You have the condition. How are you going to deal with it? And we have things to offer. It doesn't mean you need to take them, but you need to know what's available and say, well, hey, if I can treat my fatigue with all the great suggestions that Tracy had, but then also you may need to supplement that with a medication sometimes, and it can really help, and it improves your quality of life significantly. Fatigue is the #1 disabling symptom in MS. It takes a lot of energy to transmit a signal across a scar. It takes 3 molecules of ATP for every sodium potassium channel that you have to open up, that you don't have to open up if you have intact myelin. So your energy's shot by noon, 1 o'clock. You've used as much energy as I'm going to use in a day, because just doing routine things, you had to use so much more energy to get that signal across that scar. So is that how you want to live? Well, I can't go to the PTA meeting. I'm not going to go to the ball game. I'm tired. But you know what? I didn't take a medication. Or I didn't do something about it. But I didn't, and so I feel good about that. No, probably not. Okay. Bowel, bladder, sexual things. Those occur. Pain. Stiffness, weakness. We have medications that help improve walking and strength. And there's another thing, the walking pill. Has anyone heard about the walking pill? So Empira, right? But the information you get is it's for walking. And then insurance says, well, you have to have a documented speed, and then you have to see an intervention for us to continue to use it. Well, when I was at UAB in the early 90s, we used the compounded version. We used to get it from London to treat heat-induced fatigue and fatigability of speech. Speech gets blah, blah, blah at the end of the day, or vision blurs out. We used it for all of those things because it helps trafficking along scarred tissue. The walking pathway doesn't have divvies on it. It's cognitive pathway, it's every pathway. But all you hear about is walking, because that's in the label. That's how it got approved, and we can't talk about it in any kind of open, in any kind of sponsored talk, or the literature can't talk about that. But I'll write it for those things, and then insurance uses that information sometimes as you can't get it because it's approved for this, and that's it. And that's a shame, because it can improve your quality of life in other ways. And that's what all these things are for. So, that's the regulated world that you live in, and you need to know that, because you may be an advocate someday against that kind of stance, and you might feel the need to push that forward and say, that's just because it was in the trial doesn't mean it can't help me in another way, and it does help me in this way. Why can't I have that medication? Isn't my quality of life important? And then other things that help with symptom management, you heard exercise, diet, don't smoke. The better shape you're in, the better you can handle whatever comes your way. Okay. And I won't go into the things that Tracy so well spoke about as far as those interventions. Relapses. So I'm talking about a true relapse, a new neurological deficit lasting at least 24 hours. That's what we use as our guideline. Now, does it have to be 24 hours? No, that's our convention, and most of them generally do. We'll just kind of use that as a definition. Over 40% of relapses leave you permanently neurologically different. And 30% leads you 1 point permanently more disabled on a 10-point scale. And that's from 2 studies, one by Hurst and one by Lublin. And the data is well published out there. So relapses do matter. That's the one area where we're really bad in this world in treating MS. There's no uniformity at all. And what I was taught, and what's still taught in many medical schools, is that steroids don't do anything but shorten the time to where you were going to end up anyway. So if you don't like steroids, well, if you don't take them, eventually you're going to get to the same place, so you don't have to take them. That was based on an observation in a 1970 study where there were certain parameters that you couldn't treat the relapse until a certain amount of time, and then they used ACTH and the patients were better, but by 3 months they caught up. The other patients who weren't treated kind of caught up in how much they improved or didn't improve. That would never fly as a study, and to the author's defense, they weren't trying to prove anything. They were making an observation that this is what happens. We just saw that if we give ACTH but we don't chase it with anything, or we don't treat early enough, eventually that person's going to go decline a little bit, and the other people are going to improve a little bit, and you're not going to be able to tell the difference. But how it got taken was steroids don't do anything. Okay, the longer inflammation is eating away at your myelin and larger areas of myelin, I don't think that's good for you. And I may not have a study to prove it, but I really don't need a study to prove that. I want to get rid of inflammation as soon as I can so that more structures aren't damaged. And so we need to kind of set goals. Some people use 3 days IV steroids, no taper, followed by 2-week taper, 5 days, no taper, followed with this. It's all over the map how people treat relapses. So how you get treated, you should set some goals. And what I try to do is set goals. Okay, if we're going to treat a relapse, if you're not better in a week, I want you to call me, because something's going on. We need to change. We're not going to get any better magically in the next week. If you're initially better and then you get worse, you need to let us know, because we've gone below the inflammatory threshold and now the inflammation's winning. And that's very typical. Someone gets steroids and they were doing better, they felt well, and then they got worse again and they didn't follow up for 3 months, and now the deal is sealed. The scar is there. Okay, so I try to say, not better in a week, call. If you're initially better on steroids, but then you relapse back, you worsen, let us know, because we may have to go up or we may have to use something else to help treat that. And then I want to see you back in 6 weeks as best I can, because that would be the end of the treatment phase. And I want to make sure that you're back to your baseline where you were. That, for me, works to try to make sure that we're trying not to have a permanent deficit that you have to live with. Okay, so take ownership of your relapses if you're being treated. Say, is this outcome sufficient? Is this good enough for me or not? And you don't have to follow how I do things, but I would say you should set a goal in your mind of how you want the outcome to be and challenge the result if it's not where you are. Many studies now show that if you wait to treat initially with a disease-modifying therapy, you don't catch up. You don't get back what you could have saved. So the patients who were early treaters in the study versus placebo, and then the placebo patients go on treatment, they never quite get to the same level again. So that's why we advocate early treatment. We don't want you to be on drugs for the sake of being on medications or antibodies or whatnot. We want to try to preserve your brain and spinal cord. And we know it's hard to kind of get grasp on. I was cruising along, and then all of a sudden this thing hit me. And I don't know how it's going to play out. And I'm just really unsettled, and I don't really know that I want to go on a treatment. I just don't have my hands around it. Well, we need to explain the importance of why you would want to go on something. And then we have that home run of therapy. We don't want you to go on something that you don't feel well on. And as I mentioned a little bit before, those relapses do matter. They do have a high probability over time of affecting you. If you have 2, 3, you have a pretty good likelihood that one of those is going to lead to some permanent residual. "90% of MRI lesions in the brain on average don't cause any symptoms." So you can accumulate more damage without really feeling different. Now, it may be that subtle fatigue that's worsened, or that cognition. I have attention deficit. I can't multitask as well. They may be contributing. It wasn't paralysis on the right side. It wasn't so obvious to tell us this is a relapse. And then some of them truly may not cause any symptoms, but they're chipping away at your reserve. So you have less capability to respond and react to damage. So the more damage you have to begin with and then accumulate, the less likely you're going to be able to overcome some of the lesions in the future. And as I mentioned, secondary progressive is a wearing out of lesions that you accumulate. So new lesion accumulation, even if you're feeling well, you don't have a relapse, you're not worse neurologically, and you tolerate your medication, we have an abundance of studies now that show that new silent lesion predicts worse outcomes. So we need to scan every so often, and then we need, if there's a change on that, to talk about, is this still the right path to be on? Not to say you necessarily need to change, but we need to talk about it. Package inserts. So you get placed on a medication and you pull out that sheet and you go, whew, boy, this, I'm going to catch that, death, no, that's not good. Cancer, no, that's not good. Don't want to take it. Wouldn't blame you. And maybe it was because I wasn't listening in medical school or residency or whatnot, but I was never told that that was not a list of side effects. Never. I didn't figure that out until I got into doing clinical trials. And found out that in the clinical trials, every symptom someone had, we had to list as a symptom possibly related to that medication. But your husband and your child may have had the flu and then you caught the flu. Well, we have to list this medication as possibly causing the flu. And how many people get a headache in 2.5 years? Because the MS trials usually go on for a few years. Quite a bit. It's going to be listed. Does that mean that medication caused a headache when you pull that out? No. It might, but it also might not. So that's just a list of all the things that happened in the clinical trials. And you could have been on 7 other medicines that had those side effects and caused that particular problem. So don't think by reading that, oh, this is what is causative from this medication. Possibly, but it's not. I can guarantee you all of those things are not related to that medication at that percentage for sure. So you have to trust your healthcare provider, your pharmacist to some extent to say, well, really what we see most commonly are these things. And if you look at headache in the placebo arm, it was 25%, and in the medicine arm, it was 30%. So maybe 5% of people, the medication could be attributable to causing the headache. That's just kind of a rough, look at things with placebo and medication. But just by the number, and a lot of times when they have those lists of things, the people in the placebo arm had the exact same incidence. But it's scary to look at that thing. But just you need to know what it really means. And if there's some things on there that say, hey, I don't like this, you need to say, is this really, you think, attributable to the medication or not? And then you get a sense of whether you think it is or not, and then you make a decision at the end of the day. But don't just assume that's something that's going to happen, that happens to this many people because of this intervention. It's not that way. And I talked about the expected cancer bit. So I mentioned this before, sticking to the label. There are recommendations in that label that really are not very practical. Okay, so there's a medication that says you should do monthly liver function tests for the first 6 months. Well, that medication never had a significant problem causing severe liver problems. Its parent compound did in a whole different population in rheumatoid arthritic patients who were on chemotherapy agents and other things. There were just a couple bad liver outcomes there. But then to saddle it on this one and say you have to have your blood tested every month for liver function, that's not necessarily true. That's a recommendation in the label, but a number of doctors, they're not going to get sued. I followed the label. I'm going to do that. And so if I decide not to follow that, I need to tell you why so you're informed and see if you're okay with that. Okay, I don't really think we need to get monthly liver tests for first 6 months because of this reasoning. And if you're okay with that, we move forward. Okay. And there are some other ones as well. And I know I'm speaking a long time, so I'm going to kind of shorten that. There's also this amount of evidence that you don't get exposed to from good trials, trial data. So here's an example. Let's say the primary endpoint of a study is the annualized relapse rate. Does this medication versus another medication or versus placebo lessen the amount of relapses you have per year on average? That's often a primary outcome measure in our clinical trials. And the company decides what they want as their primary endpoint, secondary endpoint, tertiary endpoints, and there can be several. So the secondary endpoint is time to a relapse. Does this lengthen the time out until the next relapse significantly over the other medication or over a placebo? And then another secondary endpoint, we want to look at T2 lesion volume accumulation. So did this medication have a better impact on the amount of new volume of T2 lesions that your brain accumulated compared to what it's comparing to? And then number 3, number of new lesions. And then tertiary endpoints, active lesions, quality of life, reduction in disability. Now, how this is set up is, in a clinical trial, if you fail to show significance at one of those points, everything below it cannot be mentioned. So in this particular instance, I highlighted T2 lesion volume change. And let's say this medicine did a great job at reducing the annualized relapse rate compared to its competitor. That's good. The time to relapse was significantly lengthened on the treatment. It helped really reduce relapses and the time to have a relapse. But the lesion volume change was not significantly different. Then everything else may have been positive, really positive results below that, but you will never see it in print or hear it at a medical talk. But that's real data. That's important data. And one of the medications failed its first MRI endpoint, and every other one was markedly positive. And you never hear about it. That's important in making decisions of going on medication. Hey, this does all these wonderful things, but you're not, if you get here, go look at these go look at these promos and tell me what medicine you want to go on. That's lacking so much information that it's not really a good informed decision. You're not making a good decision because you're not armed with good information. A couple other comments, and then I'm going to go into medications and just brief bullet points about those. Stabilizing MS is what I talked about, the home run. Not having any relapses, not having any worsening, no new MRI lesions. And so that's been the goal once we had treatments. Let's just stabilize MS. That's a huge step from where we were. And then cure. So people kind of misunderstand what cure and fix are. Oh, I want the cure. Okay, well, I want a cure too, but if I was in a wheelchair, I had a hard time walking, I want more than a cure. A cure just means that you stopped any more disease from occurring and you don't have to take anything. Kind of like breast cancer. You have breast cancer, you take chemo, your radiation, 5 years later, the oncologist does a happy dance and says, you're cured of your breast cancer. You feel great. It didn't bring your breast back. Okay, so if you go on an MS medication, you take it a couple times, you never have to take it again, and you have no more new MS. And we can't say it's a cure until your last breath, but we can say, well, you have a 5-year cure. You haven't had to take anything and you haven't had any more MS. You're not taking it. You're cured of it for that 5 years without having to take anything. but that didn't bring back your paralysis or your lost vision necessarily. So the fix is remyelination, bringing back function. So you need to understand those terms when you ask questions and seek out things. I think you need to know that. All right, now I'm briefly going to go over the kind of different treatments and just bullet points about them. The injectable disease-modifying therapies, safe over 20 years. We know they're very safe. They have hit the home run. I have people on them 17 years, haven't had any change whatsoever in their MS. That's perfect for them. There are great service programs from the pharmaceutical companies. The main side effects and issues are usually flu-like reactions, injection site issues, and then maybe liver function or white cell counts and so on. So those issues are the ones that kind of usually derail them if it's not lack of effectiveness. Tecfidera is one of our oral medications. It's effective in many people. Flushing, which occurs in 40% of people, is generally manageable. We can do things to kind of manage the flushing. GI tolerability is the big issue. Throwing up, intractable vomiting, nausea, abdominal pain, or diarrhea occur in about 15% of the time. That fatal brain infection, the JC virus causing PML, has occurred 4 times in 200,000 patients on the treatment. So very, very, very rare, not like Tysabri, which has a higher incidence and association. So it shouldn't be in the same category of risk, but it has happened and you need to know about that. Incidence and prevalence are important. So when you hear the spiel, well, all the side effects, you can see the incidence of side effects is in the first month, and then it tapers way down. That's incidence. That means new occurrence. But it doesn't mean people still aren't feeling poorly out there if they stay on the medication. So it can be a little bit misleading when you hear, well, the incidence is really in the first month. Okay, but it stays with you in a number of patients, and it doesn't mean you're going to get over it necessarily. So that's its big bugaboo is GI side effects. Gilenya, the oldest oral, 5.5 years out now. It's effective after Tysabri. So rebound after Tysabri is a big problem. This has been shown to be effective at limiting rebound coming off of Tysabri. Has very good 5-year brain atrophy data. There are not negative interactions with medications, as your pharmacist will see on a screen and get this little burnt and say, you can't take these 2 medications together. That's not necessarily the case. If you're ever told that, you call the office and we say, no, that's 1 in a billion, or that's been discounted. Okay, so this one was initially thought to have some negative interactions. We also hear people go on beta blockers for blood pressure or heart rate after they've already been on this medication, and there's no problem with that. Okay, so there's again a misconception. You can't take it at the time you start the medication, but it's fine otherwise, but that computer screen will pop up that there's this problem. People on Gilenya who are diabetics, they may have a higher incidence of macular edema in the eye, so that may not be a good time or a good situation to take this medication. If you've had a heart attack, stroke, angina, TIA, that kind of thing in the last 6 months, shouldn't go on this medication. There have also been a few cases, 5 cases of PML, the fatal brain infection associated with this one. Also many, many tens of thousands of uses. There's been some infections that have occurred post-marketing, aspergillosis, skin infections, and then basal cell skin cancer has been seen a little bit higher. So having annual skin exams would be a good thing. Aubagio, the last of the orals, it's actually better than it was perceived in the trials. What's important is looking at the patients who were studied in the trials. They had disease for 8 to 9 years entering. So their likelihood of having a reduction in relapses is going to be less than people who are intervened upon early. And we saw that with the injectables. The injectables are better than the initial trials. The patients who got into those trials had disease for a long time. When we now use the injectables early, much better outcomes. So that's what we're seeing with this medication. And this is the one that recommended for monthly liver function tests, and I don't see any good evidence why we should do that. Malaise, weakness has been more of a side effect issue where people would come off the medication. Tysabri is still effective years later. PML risk does occur, has occurred in a lot of people, but it's rare. Even at 6 years, it's less than 1%. If you have the virus in your body, it's less than 1% that you'll get PML from it. It's a very effective, enduring medication. Lemtrada, so it was presented in Vancouver 2 weeks ago. Cure rate, so here, roughly, or over 50% of people have not taken any medicine to prevent relapses and lesions for 6 years. Their last administration was 6 years ago. So that's not saying it's a permanent cure. 50% is less than last year at 60%, so some people have broken through in that year. There's sustained reduction in disability. 46% of people better than when they started at the 5-year mark. We haven't had that with other medications, so that's truly a very positive part of this medication. But that you can't see that in the literature because it's not in the label. We showed in our clinic 200 people coming off Tysabri going on Lemtrada, no relapses in that population, which is astounding, and 42% of people better than they were on Tysabri. So very effective medication. We haven't seen any PML. Talked about the cancer issue where it's much less than what was mentioned as you can get cancer. Autoimmunity, so autoimmune thyroid disease, cancer issue, kidney issues and platelet issues can occur, so we have to be very mindful. Infections can be serious, so we have to be very mindful of that. And patients have side effects, may feel washed out for 3-4 months. Be patient. That's the road bump, and things typically get better thereafter. So don't be disappointed if you're on that. First 3 months don't feel very well. Okay, ta-da. I didn't get the yank, right? So, communication tool, yes. So, Land of MS is a communication tool that was devised by Dr. Steingo in Florida, and there are many of those kind of tools. And so this is a 2-page tool that can be used for patients to fill out prior to coming to the office so that you make sure you don't miss things that should be talked about. And in this, I'm just going to kind of give you broad things. Your insurance company having that information out, pharmacy, so it saves time and makes the visit more efficient. The pharmacy address, which one you're going to go to, any kind of neurological symptoms. And here they give you a laundry list, so you don't have to try to come up with them on your own. You just kind of circle: numbness, tingling, where, weakness, where, vertigo, dizziness, double vision, facial drooping, fatigue, memory issues, what's that like? List your medications, your allergies, so it's all there, so you don't have to fumble through your bag and do all these things that take time away from the visit. Date of the last lab work you had, because we'll often ask, and we have to go take time out, look at the computer. That takes a minute. That's going to shortchange our visit. When was the last MRI, as best you can recall? Have you missed any of your medications? And that's how it's stated here. I would ask it differently. I'd say, how many times have you missed your medication in the last month? Because if you say, have you missed it? Ooh, I better not say yes, because I might get a slap on the wrist. So how many times have you missed it in the last month? Oh, well, he expects I'm going to miss it once or twice, so I missed it this many times, and we have that. So different ways to do it, and this isn't the only tool, but this is a very good kind of template to use. Are you working? Do you smoke? Alcohol, caffeine, exercise, those kinds of things. Review symptoms in the different parts like GI tract, eyes, are you having any issues? And they're listed here, so you just circle them. Now, one of the problems with these things is if you hand them out and someone circles everything, okay, headache, dizzy, tired, bowel problem, we are obligated to go over those and put them in the chart if it's a document that's a part of our encounter, okay? So we're not in favor of doing that, but I think if this form, as you can see here, is on Views and News website. Okay, so you can download it yourself or create your own one and have it all prepared so you can talk about those things that you want to talk about in the visit. But it's not going to be something that's binding that we have to talk about every little symptom because our clinic provided it to you, because then we are legally responsible. And that makes sense. If you complained of chest pain, one of the symptoms out of the 55 that you had, and we didn't go over that, and you had a heart attack next week, we missed it. That's not good. We're also liable. That's not good, but that's not the main driving force. But we want to make sure we address the pertinent things that are troubling you, and sometimes it gets dwarfed if you have a lot of symptoms. So using a tool like this can really help you communicate with your healthcare provider that you have it all down, all there ready to go for your visit. It makes for a more productive interaction time rather than, okay, any more issues as we're walking out the door with our hand on the handle, right? Because we have fumbled around trying to find information that could have already been there at the visit, right? So I thank you for your attention. Thank you, Stu, for
Thank you
supporting
very
this
much.
project, and I'll be happy to answer any questions that you have.
So, in addition, though, to it being on the website, for those that have problems writing, they could fill it out online. You could fill it out right online and then just print it out afterwards. All right? So that's just something that one of the support group leaders in Las Vegas contacted us about doing this. She said she's got a lot of people in her group that would love to be able to use something like this, but they can't write. And they don't have anything that they can talk into that will fill it all out, but can they fill that out online because they don't have any problem typing into a keyboard. So then we developed that as well. So it's just something that we're giving back to the community, and hopefully you could use it for your, clinician's appointment. Okay? Only about MS though. And like the doctor said, don't fill out everything though. Don't fill out that you're having problems going to the bathroom if you really don't, but you think you do, because they don't have time to talk about it.
Or if you had it once in the last, and it wasn't, if you had an accident one time, that may be an important issue to discuss. But if it's, I was urgent because I had 3 caffeines or I drank a beer and I had to go to the restroom, or it just happened once and it doesn't seem to be an issue and you don't want to spend a lot of time discussing that, then you just kind of use common sense. Well, that's not really something I need to. Yeah, but a lot of people are rule followers. Did you ever have it? Well, I can't lie, so I'm going to say yes, and then we have to talk about it.
Okay, so does anybody have any questions for Dr. LaGanke? And if so, I'm going to be on this side of the room. Ken is going to be on this side of the room. Please raise your hands. We will see everybody. Know also, very, very important, this microphone must go close to your lips. If it's out here, nobody on there that's going to be watching this later on can hear you, right? So that's what we want to do. Ken's going to go first.
Hey, Dr. LaGanke. I just had a question. Your statistics at the beginning of the presentation, it was very disturbing to hear that all of those are from 1990. I've done as much research as I can as a layperson, and those are the same numbers that I keep coming up with. And to hear you say that those were a 1990 research study or a census, I work in the EMR world, so I'm familiar with quality reporting. And are we not developing, or is CMS not developing any kind of guidelines for reporting on claims or trying to take a census through non-invasive, where basically the physicians like you are reporting new cases, new instances?
There are rumblings to try to get a U.S. census. There are a couple of European countries that have a perfect census. Every person who's diagnosed has to go in, and it goes into the national census, and they have really good, accurate numbers. And we do that for things like TB and AIDS. We have to report that to the health department, and I think would be a good idea if we did that for this condition as well, or somebody. And again, it's not going to be necessarily perfect. I think it's important to get those numbers soon. So it's maybe let's query all of the neurologists who take care of MS patients. And there are some non-neurologists who take care of MS patients. You might miss some, but would you please fill out how much? And then you look at a sampling and you kind of make a trajectory and decide how many people there are. And again, it's not going to be a perfect thing, and all the while we can be working on a more perfect tool to capture that. But I think it's important to really get a sense of how frequent this is, so that the healthcare dollars can be apportioned appropriately.
Next question over here.
Yeah, I'm pretty new to this, but I was just curious. You said early on about symptoms and things like that, and baselines like you may want to stay the same is a good thing. Is it once you have certain symptoms, is that pretty much what you're going to have, and you're not going to really go backwards from that? You know what I'm saying?
Not necessarily. Some symptoms improve on their own. Some improve with medications, but it doesn't mean you're going to have to stay on that medication forever and ever. So one example would be trigeminal neuralgia, that extreme facial pain that occurs with MS. A lot of people will go on an anti-seizure type medication, control the pain. They do that for a few months, they come off, no episodes. It may flare up again months or years later. They have to go back on medication. So it doesn't mean that symptom's always going to be there.
And my last question is, when you're determining a diagnosis, say a new patient, and you start to study that, how long do you observe and kind of go through things to determine, well, they really have this type of MS or one type or another?
So between the different types of MS, progressive or relapsing remitting, A definition of progressive MS is a worsening of neurological function in the absence of a relapse. Now that's not, you can have maybe a subtle relapse, an unnoticed relapse, and have active lesions, and you would still be diagnosed as that. But to get to the very bare minimum of saying you have progressive MS, you would have to document a neurological worsening on the exam in the absence of any relapse and likely absence of new lesions in order to say, this looks like you have some component of progressive disease. But again, a lot of people with secondary progressive disease continue to have new lesions. So we shouldn't take away the medications necessarily, because I mean, the people who usually have secondary progressive are ones who have mobility issues. They're close to the chair or in the chair. And don't those people deserve our absolute best care to prevent their arms from going and their mind from going? So why would we take away the treatments and let more lesions accumulate to affect those areas? And yet, that's what's espoused. You have secondary progressive, we don't have any proof that any medicine stops that, so you need to come off your medications. You know, it's not good. Again, lack of evidence, doesn't mean a lack of effect. But to prove that going on a medication today is going to keep you from having progression of something 10 years from now, there aren't any studies that way, and there never will be. And so one can hide behind it and say, well, you have no proof that you're doing anything, so we're not going to spend the money for it. Well, it's just not right. Yes?
Is there one type of demographic that you are seeing that is reporting more MS, less MS, like symptoms? I guess I kind of just talked myself into a corner. Hold on.
Ask it again.
Yeah, let me get this straight. With the genetic testing that they're doing, they're seeing that there are so far 100 genetic markers. Is there one type of demographic, or females versus males, younger versus older, Caucasian, African American, any type of demographic that you're seeing a surge in diagnoses?
No, we certainly observe demographics. So females more commonly affected than males, as with most autoimmune conditions. We see typically African Americans having a worse prognosis, so you change the ante of the intervention at a certain period of time. There was thought that Th17 marker was maybe more present in one race and not another, so certain medicines that interact there shouldn't be used, but that's really not come forward full circle yet or been fully amplified yet, so we really don't have the markers yet, and the main genes have not been discovered yet. So these are sort of low incident or low contributory genes, and so the big ones are still out there for us to figure out. So we haven't seen really correlations of a gene issue and a certain demographic, but we've noticed a lot of demographics in MS and epidemiology in MS.
Okay, my question is about the subtypes of MS. One that has shown up on my primary care doctor's page that I get from them is relapsing progressive MS, and I had never heard of that from a neurological point of view.
So I commented on that briefly. It wasn't on the 3 subtypes because the classic is 4 subtypes, and progressive relapsing or relapsing progressive is a type, but it's less than 5%, and it's kind of falling to the wayside and being incorporated with relapsing remitting, because we think that people can have a worsening of their function, they haven't had enough time to recover, and they have another relapse, and it's not really progressive. It's behaving more like relapsing with active lesions that are continuing to go on. So yes, it is a listed subtype, very uncommon, and it's being swallowed up by relapsing remitting right now.
Okay, I have a question for you before we continue on with others. Going back to communication, how do you, the clinician, get patients to trust what you are going to do for them?
I think the best way is to be sincere, to try to present the information, to try not to be so dogmatic unless you truly believe that this really needs to be, and not just that you're going to follow my rules and my prescription of how things ought to be. So I think to enlist trust, it's that a person gets a sense that you're in this with them. It's not you're the team leader and directing them and they need to do what you say no matter what. It's, hey, we want to get better, and this is how I think explanation is really helpful. I think if you just say, go take this, they're like, Why am I taking that? What's it going to do? What are the possible side effects? I think explanation and discussing things to and put it in perspective where a patient can understand it is really important in them having trust. And then following up and saying, okay, well, this happened, this didn't happen, and staying consistent with the message and answering questions and being willing to say, I made a mistake, or no, I don't, maybe this wasn't the best way. And if a person gets that you're sincere and doing your best and have competency, I think they're going to trust you.
Okay. One here first, he'll come over to you.
Hi, I've got 3 questions. You mentioned your categories, and one of them is fix on medications.
Yes.
Have they found, or are they working on a fixer?
Yes, we're working on a fix. The anti-lingo study, which that antibody is, we're looking at remyelination. That worldwide study was completed in early February. We were blessed to be the highest enroller in the Western world, so we're really anxious to see how that turned out for our patients, to see if any remyelination occurred. That antibody worked in restoring some visual acuity in optic neuritis, speed of visual recovery. So it's the first evidence of human remyelination that we've had. That was a year prior. So we're hopeful it does the same thing in MS lesions, and any time in the ensuing months we should have the results of that study. And then a lot of other things are being tested for remyelination at the present time. They're being at the drawing table to work out a trial.
Okay, second question. In my age group, basically, how can you tell?
25?
How can you tell if you're just getting old and senile versus cognitive on memory and being able to talk and think of what you're trying to say?
Yep, that's a very good question, and I was asked it twice today. Is it my aging? Is it my MS? And I can't necessarily give an absolute answer every time, and kind of the pattern is helpful. So if it's, I can't remember names, and I used to remember names, and that's really the only deficit I have. That's very typical of Alzheimer's and aging. That's one of the first deficits. Now, I was never really good with names because I had so many people that I'd meet that names are hard. I can look at someone and know what's going on with them, but name association. So that's not Alzheimer's disease, at least I hope it isn't. But it's more that you were proficient and then you start not remembering somebody that you should remember. That's one of the earliest signs of Alzheimer's disease. But in MS, it's usually more, you're going to remember it eventually, or you know what you want to say and you can't get the word out, or your thoughts just leave you. More common when you're tired. Can't multitask very well. All the stimulation going through other scars just makes it very difficult to pay attention. Going from one task to the other in ADHD or ADD type of brain, that's very typical of MS. And not so much with this other condition, with these other memory aging conditions. Again, not perfect, but we kind of have an understanding. And then medications can cause side effects that'll affect your memory. Fatigue, huge issue in causing fatigue, because the brain is going to conserve energy to make it through the day, and it's going to say, I'm not going to remember things, because memory chews up a lot of energy. To have a short-term memory, you have to be recalling things. You have this little spinning wheel here that you can tap into. I got a meeting at 7. Okay, you're not thinking about it all the time, but you can go to it. And so there's energy utilized, so that when you have a lot of fatigue, often we'll see cognition is really quite poor. So when a patient comes in and say, I'm not thinking, my memory's bad, I'm just worried about my cognitive abilities, one of my first questions is, how's your energy? Oh, it's terrible. And often we'll see if we can improve the energy, cognition improves. Okay, so sometimes you can't tell. 65 and having some memory issues, sometimes it's a little bit difficult.
But not a relapse. Right.
What's that?
Okay.
Yeah.
On neuropathy, hands and feet, what is neuropathy? How do you fix it? And if you're taking a Baggio, that you seem to have it, I know somebody who has it.
Okay. So neuropathy is a description of damage to peripheral nerves. So the nerves that go to the feet, nerves that go to the hand. And that's not, of course, going to be MS, because MS affects the brain and spinal cord and not the nerves, except very exceptionally. So if a person has neuropathy, it's not directly related to MS. It's a separate condition. people with MS can have numbness in their feet and their hands, and it's not neuropathy. So it can look exactly like neuropathy because the same areas are involved, but one is due to damage in the spinal cord or brain, and the other is due to damage in the nerves themselves. So a nerve study, one of those lovely shock and needle tests, can tell you whether you have neuropathy or not. And if you don't have neuropathy, then likely it's coming from the central part, and it's more MS-related symptoms. If it's neuropathy, then it's due to diabetes or aging or medications or some other types of things. Medications, you're speaking of, Aubagio does have a low incidence of peripheral neuropathy associated with it. So if neuropathy symptoms develop after going on that medication, then we could test to see if a person has neuropathy, and related to the medicine, we don't want to continue taking the medication. Now that medication will also cause tingling. That's not neuropathy. It's not permanent damage to the nerve, but causes tingling. And for that, a person might endure that symptom or treat that symptom knowing that they're not damaging their nerves because the medication's working very well for their MS. So there you would really do a nerve study to prove nerve damage, no nerve damage.
Oh, mine was more of a statement than when he asked.
Oh, okay.
Knowing me, you know it's a statement.
Drum
But
roll.
How many of us have sat in a waiting room and not shared a story or heard what other people said about our physician? And that a waiting room's a wonderful place to help create your
It's still
your
magnolias
trust.
nowadays, right?
Oh,
Yep. Yep, it does. Yep, that's another way of trust and so on. Hear other people's testimonials.
And going back to the fix, you talked about remyelinating.
Yes.
If there is axonal damage, will progression continue to happen even if the damage is on the axon and you may remyelinate?
Yeah, that's a great question. So if you have a black hole, if you have a snipped wire, and you're not conducting anything, if you remyelinate that, do you reestablish function? The answer before was typically thought no, that's not going to help. But there's some evidence that if you can bridge that area, then you might be able to tap from one side to the other and might get function. And then you also, by remyelinating, might stimulate axon regrowth. And we saw that in the test tube with one of our oral pills. We haven't seen any evidence of that in real life, but one of the pills that we have approved led to new axon formation at the end of a cut axon. So I wouldn't close the door on that. It may or may not. We don't know. We'll have to see if we can establish function in those areas.
What do you recommend for a patient that has been taking Gilenya for several years and then is later diagnosed with diabetes? On your slide, there was something about not taking Gilenya and being diabetic.
Yeah, that's, there's not a lot of information of that situation of people who've been on Gilenya and then developed diabetes, so I don't know that there's really an accurate answer as far as that goes. It's just that diabetes increases the incidence of macular edema, and so this medication, when you go on it, can cause it. Typically, it's in the first 3 months of starting the medication. So if you've already been on it quite a while, I don't think the incidence is going to be as high in a person who develops diabetes after they're on Gilenya as opposed to someone with diabetes who goes on Gilenya. But I wouldn't hang my hat on that. I have absolutely no proof in making that statement. It's just a kind of a medical hunch that it's probably a little different scenario. So I think the incidence would be lower. You're going to have very frequent eye exams being diabetic, so that's something that I would have the eye doctor pay attention to. And if it's really working extremely well for your MS, I would probably suggest, well, I'm not going to tell you what to do, but in that situation, I would probably more likely than not say, let's stay on the medication and just have very frequent eye exams for a little while.
Question. Is there a blood test soon to be coming out as a biomarker for who's got what disease and what medication would best work for them?
No.
There's been a lot of talk about it.
Yeah, there was a few years ago about MOG, an antibody that in 100 patients seemed to distinguish those who had MS and versus those who had other neurological illnesses. And there are others coming out, and we desperately want that to be the case. We want a biomarker to give us confidence in making the diagnosis early, or a biomarker of disease progression or something. There's a lot of efforts in that at the present time. And I would say that I'm glad there are efforts and we're moving in the right direction, but I don't want to be overly optimistic at this point.
Question. Nobody asked it last night. Nobody asked it today. What's going on with marijuana?
Yeah, it's approved in a couple states. It's used in Europe. It's approved as a medication, a form of it in Europe for symptom control of management and pain. It's being studied in the U.S. and essential in the CBD oil. It was initially approved by the legislature here in this state, but then brought back to say you can only get it if you're involved in a clinical trial through UAB. So there's work forward with marijuana. There's different forms. There's a form that's available now, Marinol, that's a pill that we prescribe and have prescribed for years. And there's a lot of work on different components of marijuana for different symptoms. But in the U.S., it's not where it is in Europe.
Anybody else have any questions? Is that a question? No, sort of. I take extra fast steps when they are.
You didn't address, what did I say? Stem cell. I have MS. I have brain lesions.
Yeah, stem cells. So there's a lot of work on stem cells. There have been some positive studies with stem cells in outcomes, but they're very small. And the problem has been that different centers that study stem cells use different protocols. So there's not a uniformity. So you can't extrapolate the results here over here because they did it differently. And that's really our biggest challenge with stem cells is how do you deliver the right amount to the brain? Do you drill a hole and put it in there like we did with Parkinson's? Do you give it through a spinal taps and hope it gets that way? Do you do some spinal taps, some through the blood? But in the blood, how do they get across the blood-brain barrier? Do you give them a medicine to open it up, but that opens toxins? If you give too many, is there going to be overgrowth and maybe some really problems in the brain? If you don't give enough, you've wasted a whole lot of resources. So the challenge is in the methodology, because I think most of us believe it's going to be helpful in remyelination, but it's the methodology that's what's hindering us right now. And then those fly-by-night places say, we have stem cells, come and get them. You know, we don't have the methodology down. It's very expensive, and it kind of ruins the ability to move forward with it sometimes. And I understand people, you know, this is their one and only life and they're anxious and they want to get an intervention. I understand desperate times and desperate measures, but I would just caution that I've had some people go in other countries, they come back and they don't do very well, and I have no idea of knowing whether they got what they said they did, and they used a lot of resources. So unfortunately we're not there yet, but there's definitely work in the right direction in the United States in studies.
All right, let's give Dr. LaGanke a hand. While we're talking about communication, I want to briefly mention one more communication tool that's available to you. MS Views and News is a part of the large MS community. I have a website I run, it's actually a Facebook page I run called Alabama MS Events. If you'll go on your Facebook page, type in Alabama MS Events, it ought to come right up. You'll find on that web page, you'll find events listed for Joanne P. LaGanke MS Support Group. You'll find information that Diane Salson puts out in her newsletter. You'll find information from the West Alabama MS Support Group. Anything or any events that's happening, you can go on there and you can put them on. If you've got an event that's fixing to come up and you want to share with the state, put it on there. If it's not appropriate, I'll take it off. But that's just one tool I wanted to pass on to you. Stuart, in closing.
All right, so anyway, yes, it's after 9 o'clock at night, and I just want to thank you all for coming here again. After 10 o'clock for me, I just said that. It's time for all of you to get on home, get to bed. And I do thank you all for coming. I want to thank Teva Neuroscience again for giving us the funding to do tonight's program. Again, pharmaceutical industry really wants you all to be kept up to date with information. And MS Views and News has a new slogan that I want to share, and that is just that we believe in empowering all of you. We believe that all of you should be kept up to date with all the information about multiple sclerosis. So again, I want to thank you all for coming down here tonight. I hope that you all come to our program on August 20th, and just spread the word to everybody that you know that, there's an organization out there that doesn't get involved with a lot of the things that the other organizations do. We solely believe in making sure that you all are educated with anything and everything about multiple sclerosis. Okay? Again, thank you for coming. Good night. You turn those